Hi there, welcome back. Anna here with the Coding Guild. In this episode, we are going to discover a newly added section of the CPT book, Appendix R. What is it for and how are you supposed to use it? Let's discuss. The official title of this new appendix is Digital Medicine Services Taxonomy. The goal of it is to help us and providers understand the variety of codes available for digital medicine and usually remote services, to highlight the differences between them, and to show us how these codes work in the context of all other CPT codes. The AMA defines digital medicine services as follows. They represent the use of technologies for measurement and intervention in the service of patient health. Accordingly, all codes listed in Appendix R have to do with either evaluating or treating the patient's condition in a digital or remote manner. As the century progresses, we will have more and more digital and other service codes in the CPT set, so I guess the sooner we start organizing them into appendices like this one, the better. With that said, it is important to emphasize three things about this new table. 1. That not all available digital medicine service codes are included in the table. The aim of the appendix is to help us mentally organize the kind of services provided and not really to give us an exhaustive list of all possible codes. 2. Not all providers are allowed to bill for all of these codes listed in the appendix. Some will be open to physicians only, while others can be billed by mid-level providers as well. And number 3, some of the codes in this table are classified as evaluation and management services, but others are from the medicine section. This distinction can cause huge differences in billing, so definitely keep an eye out for this. Alright, here is an excerpt of the appendix. For the full table, please see your CPT codebook. In the header, we see the 4 main groups into which CPT categorizes digital services: clinician to patient, clinician to clinician, patient monitoring and/or therapeutic services, and digital diagnostic services. The first step in using this new appendix is to determine who the provider is interacting with. And by provider here we mean either a physician or other qualified healthcare professional. Our first option is where the provider is communicating with the patient. This can mean a virtual face-to-face visit, a phone visit, or, for example, an email exchange. The second is where the provider is discussing something with another provider. These are the interprofessional consultations by all kinds of methods, on the phone, via the patient's chart, via a video discussion, and so on. Now, the third column is more exciting. It is for patient monitoring and/or therapeutic services. Who is talking to whom here? To keep it simple for now, we choose this column when the provider or their staff is interacting with a device or interacting on behalf of a device. Think of wearables like ambulatory glucose monitor or a Holter monitor, things like that. And finally, in the last column, we have the choice of digital diagnostic services. This is where the provider interacts with artificial intelligence and algorithmically derived results. As we know, medical AI advances at a crazy speed. Machines are not only capable of helping with physical activities like robotic microsurgery, but they are also coming for white-collar functions at this point where they are analyzing and diagnosing patient data. When a clinician is using AI or AI-derived results, this is the column we have to choose. In summary so far, the provider can digitally interact with the patient, with another provider, with a device, or with AI. Once we know who is involved, we can go on to step number 2 and decide the nature of the interaction. How is it happening and what exactly is happening? And here we get introduced to several new concepts. First is the differentiation of synchronous and asynchronous services. This really is just a fancy way of saying whether it is live or not live communication. Examples for live or synchronous services are face-to-face visits, telephone visits, chat visits. During these encounters, both parties can interact with each other in real time. Examples of non-live or asynchronous communication would be emails, interprofessional consultations within a patient's chart, or for example, forward and store systems where the patient can submit data, a picture, or a recorded video message, what the provider can review at their convenience and respond to later. These choices of synchronous and asynchronous are only available in the first two columns when the clinician is either talking to a patient or another provider. And for these two types of interactions, this is really all we need to know before picking the right code for the service. Who the clinician is talking to and how they are doing it. Based on these two factors, we will assign a code from the EM section with modifier 95 or from the online digital evaluation section, the telephone services section, or from the consultation codes. On to the devices. If a device is involved, we have three subcategories to choose from: device or software setup and education, data transfer, and data interpretation. Device and software setup is an encounter between the patient and clinical staff during which the patient is told how to use and properly set up the device. This can happen either face-to-face or remotely, for example, on the phone. Please notice that I said that the encounter is with clinical staff and not with a physician or other qualified healthcare provider. Codes in this column do not have work RVUs attached to them, meaning that physician work is not included in these services. Device setup and education is expected to be provided by registered nurses and other clinical staff who are part of the overhead expenses. Or to put it differently, these are technical component only codes, but you don't need the modifier. This is a technical component without modifier TC. The second column, data transfer, is very similar. These are services where data from a device is remotely transferred to a monitoring center or a dedicated server in the physician's practice. Because this is a purely technical maneuver, there will be no work RVUs involved either. These are technical component only codes. And so much so that some codes in this column are for transfer and device supplies as well, for example code 99454. The third column, during data interpretation, the provider or other qualified healthcare professional or clinical staff analyzes the data on their own, formulates a diagnosis, and communicates it back to the patient. Due to the mental effort exerted here, these codes do have work RVUs associated with them, just like any other professional service code. To summarize group 3 of patient monitoring and or therapeutic services, if the nature of the encounter is technical only, we choose from the first two columns. If mental work and diagnosing is also going on, choose the third column. Finally, we have arrived to the subgroups of digital diagnostic services. Remember, this is where the provider is interacting with AI or algorithmically derived results. The choice here is between patient-directed versus image or specimen-directed diagnostics. Patient-directed digital medicine is when the service is aimed at disease detection or monitoring. In these cases, the patient already has an established problem needing ongoing monitoring, or they are showing signs and symptoms of a disease that needs diagnostics. Think of external heart monitors for this column that activate, for example, when they sense an abnormal heart rhythm, or retinal imaging for patients with underlying diabetes. In both cases, there is a need for disease progression monitoring or detection of possible new disease related to the known problem or symptoms. An example for patient-directed diagnostics could be code 0691T for automated analysis of an existing CT study for vertebral fractures. Here, the AI is helping the physician gathering data on the fracture and analyzing bone density at the site of this known disease, the vertebral fracture. Compare this to image or specimen-directed services, where the goal is to find clinically relevant data. The algorithm is trained to look for anything in the specimen that could indicate trouble. An example is code 77067 for a screening mammogram. Here the patient doesn't have signs and symptoms on which the exam is based. The AI is looking at the results and highlighting anything potentially suspicious for the provider. Other examples for this are multi-analyte assays with algorithmic analyses from Appendix O. These services specify a patient's risk of disease recurrence, and other probabilities of illness. Again, the algorithm is looking for something suspicious in the huge pool of data to help the physician come to some kind of conclusion about the patient's health. As of today, this column only has these two types of services. codes for computer-aided detection on radiologic imaging, and multi-analyte assay codes. Thank goodness for that. And this is all we had for this episode. I hope it clarified how and why to use Appendix R. Thank you for being here with me today. I will see you soon in our next video.